COR pulmonale. Introduction. COR pulmonale is a condition characterized by the enlargement and failure of the right ventricle of the heart due to increased pressure in the pulmonary circulation. It is commonly caused by chronic lung diseases such as chronic obstructive pulmonary disease, COPD, interstitial lung disease, and pulmonary hypertension. If untreated, COR pulmonale can lead to right heart failure, reduced cardiac output, and severe complications. Definition. COR pulmonale is an alteration in the structure and function of the right ventricle caused by a primary disorder of the respiratory system, resulting in pulmonary hypertension and right heart failure. COR pulmonale is right ventricular enlargement and failure secondary to lung disease or pulmonary vascular disorders, leading to impaired circulation and oxygenation. Etiology. 1. Pulmonary conditions. Chronic obstructive pulmonary disease, COPD, the most common cause. Interstitial lung diseases, pulmonary fibrosis, sarcoidosis. Tuberculosis, chronic lung infection causing fibrosis and pulmonary hypertension. Cystic fibrosis, chronic lung infections and mucus buildup. 2. Pulmonary vascular disorders. Primary pulmonary hypertension. Pulmonary embolism, blood clot obstructing pulmonary arteries. Pulmonary vasculitis, inflammatory diseases affecting pulmonary arteries. 3. Thoracic disorders. Obstructive sleep apnea, OSA, recurrent airway obstruction causing hypoxia and hypertension. Kyphoscoliosis, chest wall deformities restricting lung expansion. 4. High-altitude pulmonary disease. Chronic exposure to high altitudes causes chronic hypoxia and pulmonary hypertension. Risk factors. Smoking and exposure to pollutants. Chronic lung diseases, example COPD, pulmonary fibrosis. Recurrent pulmonary infections. Sedentary lifestyle and obesity. Congenital heart diseases. High-altitude living. Types of COR pulmonale. Acute COR pulmonale, sudden onset due to conditions like massive pulmonary embolism. Chronic COR pulmonale, slowly progressive right heart failure due to chronic lung diseases like COPD. Pathophysiology. Chronic lung disease or pulmonary hypertension. Down arrow. Hypoxia-induced pulmonary vasoconstriction. Down arrow. Increased pulmonary vascular resistance. Down arrow. Right ventricular hypertrophy due to increased afterload. Down arrow. Right ventricular dilation and reduced cardiac output. Down arrow. Right-sided heart failure, COR pulmonale. Down arrow. Systemic venous congestion, edema, and organ dysfunction. Clinical manifestations. Early symptoms. Chronic cough and wheezing. Shortness of breath, dyspnea, on exertion. Fatigue and weakness. Advanced symptoms. Peripheral edema, swelling in legs and feet. Jugular vein distension, JVD. Ascites, fluid accumulation in the abdomen. Cyanosis, bluish discoloration of skin and lips. Hepatomegaly, enlarged liver, with right upper quadrant pain. Chest pain and palpitations. Orthopnea, difficulty breathing when lying down. Diagnostic evaluation. 1. History taking. History of chronic lung disease, smoking, and exposure to environmental pollutants. Symptoms of breathlessness, fatigue, swelling in legs. Previous hospitalizations for lung infections or pulmonary embolism. 2. Physical examination. Cyanosis and clubbing of fingers. Peripheral edema and ascites. Jugular vein distension, JVD. Loud P2 heart sound, increased pulmonary artery pressure. Hepatomegaly, liver enlargement. 3. Specific tests and procedures. Chest X-ray, enlarged right ventricle, prominent pulmonary arteries. Electrocardiogram, ECG right axis deviation, right ventricular hypertrophy, RVH. Echocardiography, enlarged right ventricle, pulmonary hypertension, tricuspid regurgitation. Pulmonary function tests, PFTs shows obstructive or restrictive lung disease. Arterial blood gas, ABG, analysis, hypoxemia, respiratory acidosis. Right heart catheterization, measures pulmonary artery pressure and confirms pulmonary hypertension. CT pulmonary angiography, to rule out pulmonary embolism. Blood tests, BNP, B-type natriuretic peptide, elevated in right heart failure. Medical management. Oxygen therapy, corrects hypoxia and reduces pulmonary hypertension. Bronchodilators, example salbutamol, theophylline, improves airflow in COPD patients. Diuretics, example furosemide, spironolactone, reduces fluid overload and edema. Vasodilators, example calcium channel blockers, nitric oxide therapy, decrease pulmonary vascular resistance. Anticoagulants, example warfarin, heparin, prevents pulmonary embolism in high-risk patients. Pulmonary rehabilitation, breathing exercises and physical training to improve endurance. Treatment of underlying lung disease, antibiotics for infections, steroids for inflammation. Surgical management. Pulmonary thromboendarterectomy, PTE, removal of chronic blood clots in pulmonary arteries. Lung transplantation, considered in severe end-stage lung disease. Atrial septostomy, creates a shunt to reduce right ventricular pressure in severe cases. Nursing management. Impaired gas exchange related to pulmonary hypertension and hypoxia. Monitor oxygen saturation and administer oxygen therapy. Encourage deep breathing exercises and pursed lip breathing. Position patient in semi-Fowlers to improve ventilation. Ineffective breathing pattern related to respiratory distress. Monitor respiratory rate and work of breathing. Provide bronchodilators as prescribed. Teach energy conservation techniques. Excess fluid volume related to right heart failure. Monitor daily weight and intake output balance. Administer diuretics as prescribed. Educate on low sodium diet and fluid restriction. Activity intolerance related to dyspnea and fatigue. Encourage gradual increase in physical activity. Provide frequent rest periods. Monitor vital signs before and after activity. Anxiety related to breathlessness and chronic illness. Provide emotional support and reassurance. Educate about disease progression and self-care measures. Prevention. Quit smoking and avoid air pollutants. Manage COPD, asthma, and other lung conditions effectively. Regular screening for pulmonary hypertension in at-risk individuals. Avoid high-altitude exposure if prone to hypoxia. Maintain a healthy weight and engage in regular exercise. Follow a low-sodium diet to prevent fluid overload. Complications. Right ventricular failure, progressive weakening of the right ventricle due to chronic pressure overload. Systemic venous congestion, leads to peripheral edema, hepatomegaly, and ascites. Pulmonary hypertension crisis, sudden worsening of pulmonary artery pressure, leading to acute right heart failure. Arrhythmias, atrial fibrillation, atrial flutter, or ventricular arrhythmias due to cardiac strain. Hypoxemia and cyanosis, reduced oxygenation due to impaired pulmonary circulation. Hepatic congestion and liver dysfunction, congestive hepatopathy, can progress to cirrhosis or liver failure. Renal impairment, due to reduced renal perfusion, leading to fluid retention and worsening edema. Increased risk of thromboembolism, venous stasis increases the risk of deep vein thrombosis, DVT, and pulmonary embolism. Polycythemia, chronic hypoxia leads to increased red blood cell production, causing increased blood viscosity and clotting risk. Decompensated heart failure, Severe cases lead to multi-organ failure and death if untreated. Conclusion: COR pulmonale is a serious condition resulting from chronic lung diseases and pulmonary hypertension, leading to right heart failure. Early diagnosis and management of underlying causes, along with lifestyle modifications, can help prevent disease progression. A multidisciplinary approach, including cardiologists, pulmonologists, and nurses, is essential to improve the patient's quality of life and outcomes.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.